the oncology world does not really value choice, shared decision-making, and nuance when it comes to menopause and sexual wellness and intimacy and her concerns about chronic disease risks from long-term estrogen deprivation.
You are tuned into the Dr. Tyna Show with Dr. Tina Moore. For more, visit drtyna.com. On this episode of the Dr. Tyna Show, I'm diving into a heated topic that I've been asked about from so many of you, and that is, can breast cancer survivors utilize HRT? To answer that question, I brought on a world expert on the subject, and that is Dr. Corinne Menn. Dr. Menn is a board-certified OB-GYN and Menopause Society certified practitioner, as well as a fellow of the American College of Obstetrics and Gynecology. She's also a 23-year survivor of breast cancer herself and premature menopause. She's a BRCA carrier, and she uses this experience to help educate women all over the world and help them navigate these unique health challenges. She has dedicated her entire medical practice to menopause management, the unique healthcare needs of female cancer survivors, and those at high risk for breast cancer. So to answer the question, can breast cancer survivors utilize HRT? The answer is, as always, it depends. This is for educational purposes only and should not be construed as medical advice. We had a great and informative conversation that I know you're going to benefit from. So without further ado, let's jump in. Dr. Corinne Menn, thank you so much for coming on the Dr. Tyna Show today. And I'm very excited to have you. We have a very important subject to discuss, and it is the safety and efficacy of estrogen in all kinds of different situations. And you're the expert. I've been following you for some length of time on Instagram, and I love your work. I love how you just throw down. You do not apologize for it. You bring the science, you review it so well, and you're obviously a woman on a mission. So thanks for coming on today.
Thanks for having me.
Yeah, this should be super fun. So would you share just a bit of your backstory, because it matters here in context?
Oh, yeah, it sure does. So I always like to let people know that, my experience as a patient, as a breast cancer patient, diagnosed young at the age of 28, has really informed my medical practice. And in many ways, it made me a better doctor. And there's a lot of silver linings to that, right? So my perspective on what I really care about and my mission now is to really help other women navigate challenging, health situations, particularly around the issues of perimenopause, premature menopause, menopause, not only after cancer of any sort, particularly, of course, breast cancer, and we'll get into all of that, but also women in general who are the most overlooked or dismissed in this menopause movement, right? Because as we know, on social media and in the press, there's a lot of talk about like normalizing, destigmatizing menopause and talking about how all clinicians need to really level up, their knowledge in menopause care. And that's great, right? But at any event I speak at, and I know your listeners probably are like, they hear all this great information about estrogen and menopausal hormone therapy and the new guidance and all of these things, but they're like, but wait, I don't think I'm part of that. Like, I can't have it. And sometimes that is true. And we'll review where we would not use it. But we'll also review areas of where we can have shared decision-making and we can have hard discussions. Like, that's okay.
Yeah. Yes. I'm grateful for you being here to have this conversation, because it's wild. As a naturopathic physician in Oregon, I have license to prescribe, and I was never scared away from that women's health initiative. And I was trained to prescribe hormones by a very savvy hormone doc. She was always, this whole time, the last several decades, she's been prescribing to specific groups of patients who've had breast cancer. And so she manages them very well, and she's not been afraid to do it. And she's always followed the literature. And I would refer, whenever I had a patient come in who was in that category, I would say, you know what, I'm going to send you over to Dr. Peterson. That's her wheelhouse. I'm going to let her manage that, just because I wasn't entirely comfortable doing so. I wish that I had the knowledge that you share out, because it's just that gray line of like, you've really got to know your stuff to know when and where. And I think that you've done such a spectacular job of keeping up on that literature. And I'm sure your patients are so grateful to you for it, because not only are most doctors just completely, there's like a whole generation of doctors that have been scared away from prescribing hormones, period. And so they don't even know how. SSRIs are like their first line defense, and that's what they go to. And I'm so glad that it's changing with doctors like you and Dr. Mary Claire and Dr. Casperson out there, spreading the news. But that said, you're right. I get it all the time. I get hundreds of messages a month from women saying, but what about me? Like, what can I
Or what
do?
about me?
And I send them to you. I send them to your page to go get educated, or I send them to the book Estrogen Matters. Like, go get educated, go, get up on it. But not everybody wants that. They still want my opinion. So here's my opinion. I'm punting to you. I'm grateful to have you here.
Happens. Yes. So I hear from patients on Instagram, emailing me, coming up to me at conferences that they feel really left out of the conversation. And I think before we get into kind of this big, like I call it the pink elephant in the room of like, can people who have had breast cancer ever consider menopausal hormone therapy? I think it's really important for us to just kind of recognize that, the first problem is that the collateral damages of menopause, of estrogen deprivation during breast cancer treatment or after a breast cancer treatment, just recognizing the full extent of the symptoms and the impact of adjuvant endocrine therapy, right, which is ovarian suppression, medications like tamoxifen or aromatase inhibitors. What I find is the general medical community doesn't even recognize the symptoms, right? So like we are starting from a place where women and doctors don't know, they're not counseling women on the full extent of what's happening, right? That it's more than just hot flashes and night sweats and maybe a little vaginal dryness, right? But that's what a lot of people are told, right? They don't understand the full extent. And so a lot of times we've got to start from, kind of this like first step of being like, okay, let's get a hold of like one, what is actually happening when you have, that estrogen deprivation for a period of time, and understand that it's worse for women who are younger. So the younger premenopausal women who are thrown into abrupt surgical menopause or medically induced menopause, how that is different than a natural menopause. And that we also have to kind of break out the different stages of survivorship, right? So like how we might manage your menopause when you're first diagnosed, or you're in the middle of active treatment for estrogen receptor positive breast cancer, that might look a little bit different than how we're going to manage it once you're done with kind of any of these hormonally driven treatments. And then it will also depend on what type of breast cancer you had, right? Because this idea that we're lumping everyone who's been touched by a breast cancer diagnosis in the same, we're putting them all in the same bucket and managing them the same is totally crazy, because breast cancer is heterogeneous, meaning each breast cancer is actually quite different between the stage, the node status, the estrogen receptor positive or negative, HER2 positive or negative, other factors, right? And so it's not a one size fits all approach. So like we have to start with that, right? And anybody out there saying a hell yes or a hell no to anything is not giving you nuanced care, right? And so I think I always like to kind of like start out with that framework. Does that make sense?
Yeah, absolutely. No, absolutely. So
Yeah.
can we talk a little bit about just the standard of care in breast cancer and how it goes down? Because I've seen several girlfriends go through this now, and basically they have their breasts removed, they get put on tamoxifen. I have watched that just devastate them because they're thrust into this medically induced menopause, I guess, in that situation. Or like you said, perhaps a surgically induced menopause where women are having ovaries removed and, full hysterectomies. And I've seen young women, surgically induced menopause, absolutely no support given, no discussion, no conversation. 6 months later, they're 30, 40 pounds overweight. They can't tell their head from their butt. They feel awful. And it's like hell. And it's so bewildering to me because I'm thinking, if you remove a male's testicle, I'm pretty sure they probably have a conversation about that. Or if you remove a thyroid, there's a conversation about replacement. But for some reason in our cohort, that doesn't happen.
It doesn't. And, the American Society of Clinical Oncology, the Menopause Society, there are practice guidelines on this. There are standards of care of what we should be talking about. But just like that, the average physician out there doesn't have much training in general menopause. And the current medical system where people are kind of being seen in these insurance-based models where they're being seen in like 15 minutes, frankly, the doctors don't have the training and they literally don't have the time to even deliver this care in a way, and so that's a part of the problem as well, right? And then we always have to remember that the Women's Health Initiative, which we learned a lot of good things from, I never want to like throw that study out, but there's a lot of misinformation from that study and a lot of fear that was generated. So that's always living in the back of people's minds. So when they hear the words breast cancer and estrogen, like their eyes just glaze over and they're like, yeah, we're not talking about this, right? So, what, in terms of like, what is the basic standard of care for anybody like kind of listening to it? It really depends on your breast cancer, but to kind of keep it simple, about 80% of breast cancers are estrogen receptor positive. And so the vast majority of breast cancer patients are going to be offered some sort of what we call adjuvant endocrine therapy of some sort, because targeting these estrogen receptors. And like, we should just set the record straight that if you have estrogen receptor positive breast cancer, it does not mean that estrogen caused your breast cancer. Okay, that is very, very important to understand. Every tissue in your body has estrogen receptors. Normal, healthy breast tissue in babies and in girls at puberty and in women in their reproductive ages, in their 20s and 30s and beyond, their breast cells have estrogen receptors. Healthy breast cells have estrogen receptors. Your bladder has estrogen receptors, your gut, your skin, et cetera, your brain, right? So if you have a breast cell and it's become cancerous, right, and it's an estrogen receptor positive breast cancer, it means that breast cancer cell, as it's changed into cancer, has retained and it's sometimes overexpressing the estrogen receptor. Whereas triple negative breast cancer, it doesn't express receptors anymore to estrogen, progesterone, right? Or to what we call, HER2. So, and so what women have to first understand is that when your oncologist is talking to you about how are we going to target your cancer cells so that your cancer is less likely to come back, well, if you're estrogen receptor positive, we have a way to target those cells, okay? But that's a very different thing than saying that estrogen caused your breast cancer, right? So that's an important thing to understand. And so that if you can understand that, then you can say, okay, I've had ER positive breast cancer. I've needed chemo, maybe not. And that depends on the type of cancer and, your risks and stuff. But at some point, if you're ER positive, they're going to say, okay, now we're going to offer some type of, hormonal therapy with either tamoxifen or an aromatase inhibitor. Tamoxifen blocks estrogen receptors on breast cells, and it blocks, but also promotes receptors in different parts of the body. So it's kind of a mixed package. So it's selective estrogen receptor modulator. So it's selectively blocking some receptors, some places, and other receptors. It's promoting that. Like tamoxifan's not negative on the bone in a menopausal woman. Whereas aromatase inhibitors only work if you're already menopausal. So that's why a woman who is using an aromatase inhibitor either has to already be in menopause naturally, or she has to surgically remove her ovaries, or she has to have a medication that induces menopause, like you alluded to, called ovarian suppression, right? Medications like Lupron or Zoladex, those are the brand names. And so when we're talking about premenopausal breast cancer, there are studies that have helped oncologists decide who gets what, like who can just get tamoxifen and still have estrogen in her body, right? Like she's premenopausal. And then there's some people who are recommended to have ovarian suppression with tamoxifen. And then the most quote unquote extreme version of adjuvant endocrine therapy would be to have ovarian suppression and an aromatase inhibitor. And just at the American Society of Clinical Oncology annual scientific meeting, the 15-year data on those three basic arms was presented, and it showed that yes, there is some recurrence risk and overall survival benefit at 15 years for some women. For some women who are at higher risk of having recurrence. Whereas in other lower risk women who are maybe over the age of 35, who didn't have a lot of positive lymph nodes, who had a lower grade tumor, a better overall prognosis, those women didn't really gain much benefit for having the more extreme. But there are some women who did have benefit, right? And so again, it must be individualized. And I think you probably see this, and I have seen this personally, that there's been a trend to extreme for everybody, that I see women who are really struggling on aromatase inhibitors and ovarian suppression. I'm like, okay, you've done this for 4 years. Has anybody actually told you you're such a low stage and grade that actually you're probably getting minimal additional benefit from this more extreme measure, right? And so let's talk about that. So that's why these are the baby steps of approaching this menopause in breast cancer, because for some of these women, part of their solution is to just de-escalate their treatment a little bit. Like I say, you can have your cake and eat it too, right? That's step one. Now, for the people who really, we've decided that there is a great benefit of this time with this, ovarian suppression and aromatase inhibitors, well, we better lean into our toolbox and beyond an SSRI to help her menopause, right? But what I see is that patients don't get much support at all. They're not given vaginal estrogen, which we can talk about is safe for all these patients, and they're not given the full supportive picture of the lifestyle, the nutrition, the exercise, as well as pharmaceutical and other things that we can do outside of hormones, right? And we can certainly talk about that, but I know you want to get into hormones. And then we also have patients who are already menopausal, and those patients are not given ovarian suppression. They're already in menopause, so the knee jerk is to put them on an aromatase inhibitor. But those women could also consider tamoxifen, and they're very often not offered that, right? And there's pros and cons to aromatase inhibitors and tamoxifen. My point is, if you're in the middle of treatment and suffering, you have to know that there is nuances between these treatments, right? And what I see, particularly when I talk to a breast cancer patient dealing with a lot of collateral damages, I say, okay, time out. We're going to do a systems-based approach, and we're going to go through your symptoms, and we're going to separate them out. I want to hear about your joint pain. I want to hear about your sleep. I want to hear about your hot flashes and night sweats, but I also want to hear about your sexual health, your urinary health, pain with sex, et cetera, because we might be able to treat some things with local low-dose non-systemic hormones. And it's really amazing when you've got somebody who is struggling with hot flashes and the night sweats and the joint pains and some brain fog in this, but they also then have no sex drive. Sex feels like the Sahara or like knives, right? They've lost intimacy. They're getting up multiple times to pee at night because they have urinary frequency and urgency. And I say, if I could just fix this one aspect, do you think the other things would be more tolerable? And they're like, yeah, because I've lost control of all parts of my life and no one has helped me with any of them. So this is where I think for breast cancer survivors, because we're going to talk about how the data is not crystal clear on what's safe and what's not hormone therapy, but that we do have data and we can lean into that. But what we have really clear data on is local vaginal hormones, and that is not even being addressed. And you know why? Because I think that it's written off as just some vaginal dryness when it can have profound implications. And I've had patients tell me, Dr. Menn, now that sex doesn't hurt, my bladder health is better, I'm able to, kind of get control of that part of my body back. Now I'm feeling a little bit more resilient, and now I'm ready to, let's tackle the next part, right? So that's one way of breaking it down, because it can be overwhelming. And sometimes it's not a home run, let's prescribe you HRT. But then we get to a point where patients want to have that discussion. They're like, okay, I've done my duty. I've done my tamoxifen. I've completed my aromatase inhibitor, or I've done it for as long as I can. And I've made the decision that I'm stopping it, and now I'm moving on to this next phase of survivorship. And I've got the rest of my life ahead of me, and I'm in this menopause, and I have all these symptoms. Is hormone therapy an option for me? And so I think that, this is a pink elephant that we can't avoid. We've got more than 4 million survivors out there. And so what I say is, let's look at the data that we have. And so you alluded to Estrogen Matters, a wonderful book, and Dr. Avram Blooming and Dr. Carol Tavris, kind of reviewed the literature, particularly on what does the science actually say? And so if we want to get into that now, let's get into it.
Because he's written a few different publications and broken it down. I mean, his history is that he was a oncologist, right? Like a breast cancer oncologist. So Yeah, I'm blown away every time I get my hands on anything he's produced because it's not the
Yeah.
story we've been told.
So this is what I think. I think we have a body of literature that has gaps in it. It's not perfect data, but women right now dealing with menopause after breast cancer, we don't have time to wait around for another 20 years for randomized controlled studies and to get perfect data. And as a breast cancer survivor myself, I know that through many times in my treatment, I had to make hard decisions about what's the next best course, right? And and we made decisions based on the data that was at hand at the time, right? And so we're big girls. We can make hard decisions, right? And I'm gonna, before we even get into the HRT after breast cancer, I like to use this illustration about pregnancy after breast cancer as a really, really good example of shared decision making and taking observational data and presenting it to the patient and saying, all right, this is how we can proceed. So back in 2002, when I was 2001 into 2002, when I was in the middle of my treatment, there was a lot of observational data, so not randomized controlled studies, suggesting that pregnancy after an estrogen receptor positive breast cancer seemed to be safe, right? And that it didn't seem to increase the risk of recurrence in the short term or long term or the risk of death. But we didn't know. We didn't know exactly. But at the time, I was really lucky. I was living in New York City and I had access to lots of doctors. And I was referred to the leading expert, Dr. Octay. He was at Cornell at the time. And he was doing studies and research on fertility preservation for cancer survivors. And my breast oncologist, as well as many of the breast surgeons I saw, said throughout my whole, while I was trying to decide on even, before I even had chemo or surgery, they said, well, maybe you want to just start with a lumpectomy because you might want to get pregnant one day. And so I remember that always stuck in my mind. So way back then, they were already planting the seed that at some point I might be able to actually have pregnancy. Now, what does that mean hormonally? That would mean not being on estrogen blockers. It would mean having very high levels of estrogen for over, 9 months, right? And then maybe even after, because they're talking about breastfeeding and then, and so that always kind of stuck with me, right? And so they said, yeah, because the observational data suggests that. So this is shared decision making. And so I was lucky, and a lot of women back at the time did not get that same care and access to fertility preservation, and it still can be a problem. But in general, the oncology community has embraced, supported, researched, studied, and written guidelines on how to counsel women, and that breast cancer survivors can be offered pregnancy after their breast cancer, to the point that they made a randomized controlled study, and it was released a few years ago in the New England Journal of Medicine. It's called the Positive Trial, and they looked at patients who are exactly me. I always say I was the positive trial, but only 24 years ago, right? So back when I was, finished my chemotherapy, I was on tamoxifen for a few years, and I said, okay, I really want to get pregnant. They says you can pause your tamoxifen, get pregnant, and then you'll go back on the tamoxifen. I said, okay, deal. All right. They said, based on observational data, right? Not perfect data. And I did that. And it's good. And my daughter's now almost 21, right?
Ah.
Yeah, which is great. And so that was shared decision making without perfect data. Now we've come a long way. We've accumulated more data. And then there was a randomized controlled study that looked at this very question. And what it found is that it does not appear that there is any increased risk of recurrence and that women can do this. So I said to myself, I says, wow, we value a woman's choice on how she's going to live her life after cancer and allow her fertility treatments, IVF, pausing aromatase inhibitors, getting pregnant, maybe even breastfeeding if they still have breasts. But a woman who is, maybe a number of years, 5 years more after her breast cancer treatment ended, maybe she had triple negative breast cancer and she never even had hormonal suppression. Maybe she just had DCIS and a bilateral mastectomy and she had normal periods for 7 years, right? High estrogen levels. Then suddenly she goes through natural menopause. And God, we can't have a conversation with her about using the lowest amount of a FDA-approved estrogen patch and a little bit of progesterone to ease suffering and protect her against osteoporosis and other benefits that we know exist. And we can't even have that conversation. They're shut down. I said, so I've come to the conclusion that we value choice and shared decision-making when it comes to our reproductive capacity. But when our questions extend beyond maintaining our fertility. We do not value, in general, I value it, but in general, the oncology world does not really value choice, shared decision making, and nuance when it comes to menopause and sexual wellness and intimacy and her concerns about chronic disease risks from long-term estrogen deprivation. So I find it almost, I find it puzzling and actually really, I just find it absurd that we would have one conversation about letting you have a baby, but we won't let you have any conversations about using the lowest, kind of needed dose, to help you with symptoms as one option. Like, what's that about?
Yeah. Well, it's interesting. Middle-aged women are just forgotten, period. I mean,
Yeah.
I think we're the first generation to really fight back on that. And,
Yes.
back when we were young, women our age looked like the Golden Girls.
Yes, I don't look like I hope you don't think I look like the Golden
No,
Girls.
neither of us do. And every single woman, I remember my mom, when I was a teenager, my mom fighting tooth and nail just to keep her ovaries and uterus because everybody just got a hysterectomy. And then I saw, and I thought, I really thought that brutality had ended. And I saw a stat the other day on another Instagram showing a study that 45% of women end up with a hysterectomy and 90% of them don't actually end up needing it, something like that. And I was like, what the hell is going on? Like, we're still butchering women for the sake of the old guard. I don't get it. But all that to say, so my practice was predominantly, when I was running my big clinic, was regenerative injection therapies. And so I was taking care of people who had chronic musculoskeletal pain. And the amount of middle-aged women that came through my door, I was predominantly middle-aged folks in general, but for certain people, and this is what I always try to express to my followers, we're not all the same. We don't all have the same engine. We don't all have the same receptors. And so for some of us, losing estrogen equates to psychosis. And we have the stats on that and the suicide rates that happen in middle-aged women. I mean, one day you're fine and the next day you are off your rocker and you're morbidly depressed and you can't move. And then couple that with debilitating, crushing pain for many of us. And it's like somebody flipped a switch and you are now in hell. And now your knees are going, now your hips are going, and these women are getting bilateral orthopedic surgeries, and orthopedic surgery begets more orthopedic surgery. And just the spinal contribution, the actual breakdown of the spinal column that happens when you lose estrogen and you lose your hormones, it's unbelievable. And to think that these women are just like, oh, sorry, you had cancer, you're screwed, you have to live with this. I mean, that just seems like hell on top of hell. And it seems quite unnecessary.
So make it a 28-year-old who then, has been told it's 10 years of this. Now, listen, I work with breast cancer patients all the time who I say, listen, you need to have this treatment and we are going to help you get through it, because we can't expect that we want women to benefit from these treatments, but then not be able to exercise because their pain is so bad, right? We have to balance these things. So, interesting also data coming out of ASCO is that it was a study, and I won't have the details exactly right, but it was people with more advanced colon cancer. And it showed that exercise was improving recurrence rates even more than the drugs they were on, right?
Yep.
So I guess my point is we always have to balance it. So if I say to a woman, listen, if life is so bad for you and you're feeling so bad on this and you can't do these other things, well, something's got to give and something's got to change. We have to look at the big picture, right? And so when we get to the hormone question, menopausal hormone therapy after breast cancer diagnosis, I think the way I like to approach it is we need to look at what is your baseline risk of recurrence? Number one, right? And it's different for different people. So, when we talk about, and we're diagnosing patients at an earlier age, but also at earlier stages, which is great, right? Earlier stage, they have a better prognosis. So when I see a DCIS patient who's had a bilateral mastectomy and never needed tamoxifen, she's a very different person than someone who had a stage 3 ER positive breast cancer who has multiple positive lymph nodes, right? Those are different people, as is the triple negative patient. And so we have to think baseline recurrence risk. We also have to talk about recurrence patterns. So for instance, a triple negative say an early stage triple negative breast cancer patient. We know triple negative breast cancer most likely to recur, if it's going to recur, in the first 2 to 5 years. It peaks around year 4. So if you've got a triple negative patient who comes to me and they're like at 6 years out, 5 years out, and they're likely, like if they were going to recur, the data is pretty clear that they would have probably recurred. And estrogen deprivation was not part of their treatment plan, right? I use example of my friend who's public and she's been on, Instagram Lives with me, my friend Jamie, who had triple negative breast cancer in her late 20s. She had her chemotherapy. She went on to have many years of normal hormones being produced. She had twin pregnancy. And then right before the age of 40, because she was a BRCA carrier, she had her ovaries out only to lower her risk of ovarian cancer. And if she wasn't BRCA positive, they would have just let her have her hormones being naturally produced from her ovaries. But the ovaries came out and there was no discussion, no vaginal estrogen, no progesterone, no testosterone, nothing. So then she suffered for a bunch of years. And then she finally was like, and so I saw her and I said, okay, let's be common sense about this, right? And so we worked with her oncologist and they're like, oh yeah, you could go on it. And I said, but did anybody ever discuss this with you? She didn't even have much of a pushback, right? Now, so that's an example of nuanced care. We're looking at her as an individual breast cancer patient. Unfortunately, when we look at what data do we have to support us in our decision-making about this? So basically, and if anybody wants to look at a great summary of this, the book Estrogen Matters has a whole chapter on this, which really he explains where we are with the state of data. But basically, we have a lot of observational studies and we have a few randomized controlled studies that were stopped short because of a number of things. One, because of the background of the Women's Health Initiative, they were all being done around the same time. But these were randomized controlled studies of breast cancer survivors taking hormone therapy. But we're talking about these were studies that were done in the early 2000s, right? So it's been over 20 years since we've had any new randomized controlled studies. So we're leaning on these old RCTs, one of which showed an increased risk of local recurrence, not distant recurrence or mortality. That was the Hobbits trial. And then at the same time, it was another study going on called the Stockholm trial, which showed the opposite, that there didn't appear to be an increased risk of recurrence in the short term, or at the follow-up, I believe it was around 10 years when they looked back to the data. The problem is both of the studies were stopped short. They never got their full recruitment that they were looking for to power the results, right? And so we're left with those very imperfect studies, which basically negate each other. And then the observational data was all leaning towards that it didn't appear to increase recurrence, that it was either neutral or even an improved rate. Now, the improvement may be because in observational data, you're looking back, you're not randomizing these people. It could be the healthy woman effect, meaning that people who are less likely to recur were the ones who are more likely to use hormone therapy. Hence, they had overall a better prognosis, right? But to say that we have no data on this and shut the conversation down is not being honest. We have over 25 studies. They are far from perfect. Some are old, some are small, some are larger. But the other thing I also point out is because this data is so old, we also have to recognize that the people who were in these studies were treated substandard to today's standards, right? So the studies included women that were treated in the 80s and in the 90s before we ever had things like oncotypes or deciding who got chemotherapy and who didn't. So many of these women maybe needed chemo but didn't get it and vice versa. This was before Herceptin, before we even knew about HER2. So I try to tell patients we've got a lot of observational data and a couple of randomized controlled studies, both that suggest that there was no increased risk of mortality or recurrence, distant recurrence. And these people were treated substandard compared to what you were treated. So, kind of thinking logically, you're treated even better than these people were. So at baseline, your recurrence risk was lower to begin with. So we can have these intelligent conversations with women. And I say, and then we can look back at what, so these were original studies, whether observational or randomized, but then there's over 20 meta-analysis where they kind of rehash that data. And Dr. Blooming and Dr. Tavers present that in Estrogen Matters and other publications. And a recent one, which was published in the Menopause Society, I think in 2023 out of Spain, they looked at a number of studies, and then they tried to like separate it out, estrogen negative versus estrogen positive. And what they said is, what they found, again, with the limited data, is that there is no data to suggest that people who are estrogen receptor negative, who used hormone therapy after breast cancer, had any increased risk of recurrence, right? So again, we can start to, that gives us a little bit more reassurance. And then the newest thing that was published was the Menopause Society just published a practice pearl on how we should approach this. And they basically, kind of the bottom line is, we've got millions of women suffering. This question is not going away. We have imperfect data, but we can do individualized care and shared decision making. And we can start with lifestyle. We can start with non-hormonal treatments. We can start with, tailoring adjuvant endocrine therapy to make it more tolerable. But when push comes to shove, we can have these discussions with informed consent, right? And I think that is where we're at now. But what is happening is that part doesn't happen.
No.
The shared decision making, informed consent.
No, that's key. This is risk tolerance. This all comes down to risk tolerance. And I had a colleague who was talking to me about a patient, and she said this poor woman, this is just an example so people understand. This poor woman, her vaginal tissue was so severely atrophied. She was not sleeping. She's estrogen positive breast cancer history. She was not sleeping. She hadn't slept in a decade. She was in hell. Her marriage was in hell. Her husband and she were starting to consider living apart. Everything was falling apart for her.
I hear these stories all the
time. Her musculoskeletal situation was a wreck, and she was like, everything was tearing constantly. And I said, hey, you know what? Here's some data. I sent her every study I could get my hands on. I said, talk to her doc and just see if he would consider. And after it was all said and done, her doctor agreed to give her a little bit of estrogen. And she was and it was it was just risk tolerance. Like you said, shared decision making. She knew the risks, but the risk of not being able to exercise, having your joints fall apart, running the risk of getting, we can talk about what happens to the poor vagina and the risk that they run with UTIs and with death, all the things, right? And she's back sleeping in the bed with her husband again. And like the risk of obesity, not exercising, not sleeping, like what does that do to your cancer risk, right? Like these are huge factors when it comes to cancer risk. These are
huge factors. I love that point. It's so important. We know that metabolic health in terms of insulin resistance, metabolic syndrome, the risk of diabetes, the risk of visceral fat accumulation, the risk of chronic insomnia. I will tell you personally, one of the hardest things for me during my abrupt, prolonged premature menopause was the lack of sleep. Okay. I don't think I slept well for over 20 years, and it really impacted me. Right. Luckily, I think I was doing enough healthy behaviors that I somehow muddled through it, but it was not easy. And it wasn't until many years later, and I'm very open about this, I made the decision, and it took me a long, long time to make this decision, that I decided, a number of years ago, to start the lowest amount of a transdermal estrogen patch and some progesterone at bedtime. And I became consistent. I took my own advice and became consistent with vaginal estrogen. And it changed my life, and I feel much better. And I've learned how to, talk to patients about that, but also sometimes offer parts of that for patients, right? Getting to the point of like, all right, we're going to pick one thing and we're going to work on it. Okay. And some people have a lower risk tolerance. Some people have a higher risk tolerance. Some people psychologically can't even consider the thought of ever considering it. And you know what? That's okay. Because I promise her I can help her, we can manage. We're lucky. There are non-hormonals out there, and we don't have to get all into them, but the Menopause Society has a really beautiful practice statement on all of the evidence-based non-hormonal medications. And it's not just SSRIs now. Oxybutynin, gabapentin, we've got fezolinean, there's a new one coming out on the market, right? So those can be useful, right? Are they perfect? Absolutely not. Can they be useful? Absolutely. Nutrition and exercise as medicine, I honestly look back and it is actually shameful that our medical system, but I don't blame the doctors. It's really the way the system is. The prescription for exercise and nutrition should have been as important as my prescription for my tamoxifen, but I had no support on that. And yes, I'm a doctor. I could have figured it out, when I look back, I didn't do the right things, or I didn't even have the support around the right things. They seem like extras that are hard to like figure out, but that should have been part of it. And so, I think I'm always like very careful about wanting to make sure we always bring that back in, because I don't want any breast cancer survivor to think if they choose not to ever consider hormone therapy after breast cancer, or if they're really not a good candidate for it because they've got to stay on their aromatase inhibitor, or they're at very high risk of recurrence, and we're concerned about that. I don't want them to feel that all's lost. So patients say to me, but Dr. Menn, what about my cardiovascular risk and my dementia risk? I said, well, yes, of course, estrogen can be helpful when we start it earlier for that, right? And we know that can be beneficial, but I don't want anyone to ever think that if they can't take systemic estrogen, it means that it's all lost. And I say, heart health is brain health, right? So whatever we can do to keep your cardiovascular system healthy, and sleep health, right, is overall health, right? So we have to focus on that, right? And this is why sometimes, when I present to patients and even a medical oncologist, like this concept of hormone therapy, like I think people think that it's like high doses of hormones, right? And when I say, okay, let's just think about this, a 0.025 patch raises an estrogen level in the serum. If you look at the package insert from the pharmaceutical company, right, a 0.025 patch will get your serum level up to about 25, maybe 30, if we're lucky, picograms per ml. All right. When you have your normal menstrual cycles, your estrogen levels goes all the way up to 400, 500, even higher every single month. So we're not talking about and for many women who have been estrogen deprived for a long time, giving them back like very small amounts.
Just a touch.
Relieves a little bit of suffering. Sometimes, we'll consider just progesterone only.
Mm-hmm.
A nightly dose of progesterone we have some data that it can help with night sweats and some hot flashes, and it does help with anxiety and sleep.
Mm-hmm.
So sometimes that's something kind of we can start with if we've, tried other things that are not helping with sleep, because, sleep, if you don't sleep, I don't care what else we tell a woman to do. It's just impossible. Like you can't exercise or do, or function in a relationship or function at work, right? So those are like, yeah, it's hell. So like low doses, and then kind of really, really hammering home how important local vaginal estrogen is. And then the testosterone questions, the other question I always get asked. And I think, we have way less data on testosterone after breast cancer, but we can also take like logic and available data that's out there. And, testosterone, when given in physiologic levels to get a woman within the higher range of a physiologic level for a woman, there's no data out there on earth that suggests that it raises breast cancer risk. We don't have much data studying testosterone in breast cancer survivors, but we also know that lowering it to sub levels isn't a targeted treatment. So do I think it's an option for breast cancer patients? Yeah, I think with shared decision making, it is. And we have to remember a lot of breast cancer patients have lost their ovaries. So their testosterone levels are already in the tank because, your ovaries produce about 50% of testosterone. We desperately need more data in all of these things. But when a patient is told we can't do it because we don't have perfect data, I say she doesn't have time, because that data is not going to be here in the next 20 years because no one's doing it. There are no ongoing randomized controlled studies looking at this question, unfortunately, except, and I want to talk about Duovit with you because I think this is really exciting and interesting news for breast cancer patients out there. So if you want to, we can talk about that. So the American Society of Clinical Oncology annual meeting just presented the preliminary reports from the PROMISE trial. So the PROMISE trial it's a multi-center trial in Northwestern, other major centers throughout the US. And basically the PROMISE trial was looking at newly diagnosed DCIS, ER positive DCIS patients, okay? And they were given Duovit. Duovit is the brand name of conjugated equine estrogen and beta-doxivine. Right. So it's a combination hormone therapy that has been FDA approved for well over a decade. And it's FDA approved for hot flashes, night sweats, and preventing osteoporosis. So standard fare hormone therapy, right? But researchers knew that basodoxifene in Duovy functions, it's a SERM, it's selective estrogen receptor modulator. I like to tell patients it's a fancy cousin of tamoxifen. So it blocks the estrogen receptors in the breast tissue and it blocks estrogen receptors in the uterine tissue. And it also degrades the estrogen receptor in breast and uterine tissue. So it's very profound, the impact, but it's very selective, meaning it's not messing around with the estrogen receptors other places. It's very, very selective. So it's a special SERM, so more selective than tamoxifen. And so researchers years ago found, well, if we pair it with just the right amount of conjugated equine estrogen, which was Premarin in the WHI, right, we get a nice complex medication that they marketed as Duovy, and it works great for hot flashes, for night sweats. It prevents the bone loss. You get the sleep, all these benefits. And it seems to be really protective on the breast tissue.
Amazing.
Interesting. So they says, what if we give it to patients who have DCIS at diagnosis? What happens to that DCIS? So we finally got the preliminary data at the abstract. And what it showed was that what they were looking at was a marker called Ki67, which anybody who's had breast cancer probably has heard of this. Ki67 is kind of like a rough estimate of how aggressive or how rapidly, I should say, cells, that breast cancer cell is dividing, right? And so when the Ki67 goes up, it means things are growing. And when it goes down, it's in control. So they were looking at a marker of this because they wanted to do a short window of opportunity trial. What they mean is they gave the Duovy in the 4 weeks between being diagnosed and having their DCIS removed with surgery, right? And then they saw on the final biopsy, like what happened, what changed with Ki67, and the Ki67 went down, right? So Duovy, estrogen, right, with this basodoxifene, cut it down. And there's other research that supported this showing that when we give women Duovy, we don't see proliferation of breast cells. We don't see breast tenderness. We think it's quite protective. So I'm very excited about this as an option for current breast cancer patients who are considering hormone therapy. We don't have the data in it yet, no. But if someone is going to, when push comes to shove and we're saying like, what are the options for this woman for hormone therapy? We've got this new data out of this study, and I'm like, this is an interesting option. Do we know that it's better than a transdermal estrogen and progesterone? No, we don't. This is a data-free zone, but it's interesting, and I want women to know about this. This is also an interesting option for somebody who doesn't have breast cancer, but maybe they had something like LCIS or atypical ductal hyperplasia, or they have a very strong family history of breast cancer, a very dense breast, or they had a lot of breast tenderness when they tried, an estradiol patch or, pill or something. So Duovy, they don't get any breast tenderness. There's no changes in breast density. It seems really great. And there's preliminary data suggesting that this may lower your risk of breast cancer. So what I tell patients, what we know is we look standard FDA-approved hormone therapy, I don't believe is further increasing your risk of breast cancer. But this may go a step further and might in the future be a way to lower. So there is this very promising option on the horizon, and I'm excited to see these results are going to set the stage for more studies in this medication and others like it. So that's one little glimmer, I think, for patients to be excited about for the future.
That's awesome. No, that's great. And I mean, at least it shows that somebody's thinking about studying it.
Yes. Yes. And I think
huge.
because there's plenty of breast oncologists and breast surgeons out there. They know this is a problem. They're seeing it every day that these women are not tolerating their treatments and afterwards they're really suffering. And, the numbers are stark. It's all over the map, but up to 50% of people don't even complete their tamoxifen or their aromatase inhibitors because they can't handle it. And because no one's addressing the collateral damage, right? And so this is why an interesting study that was also just published showed that women who were breast cancer survivors who used vaginal estrogen had a better prognosis and a lower mortality than those who didn't. Now, some of that could be bias of healthier women who were less likely to recur, were more open to using vaginal estrogen. So we can't draw hard conclusions. But there is an idea that perhaps some women would actually stay on their tamoxifen. They'd finish out their aromatase inhibitor and get whatever benefit they're getting from it from lowering their recurrence if someone actually treated their genitourinary syndrome of menopause effectively. Because I'm sorry, hyaluronic acid doesn't stop UTIs, It will not prevent clitoral atrophy, and that is what is happening. Let's call it what it is.
Mm-hmm.
It doesn't change vulvar atrophy. Hyaluronic acid, moisturizers, coconut oil, it's a comfort measure. There's nothing wrong with that. It will help protect the tissue and make it, moisturize and better, but it's not going to reverse what's happening. And when you're talking about aromatase inhibitors, make no mistake about it. This is clitoral atrophy, vaginal stenosis, and it's profound impacts. And we don't tell patients that.
No, and
it's wrong.
It's very wrong. And I did a lot of stem cell therapies, and I had a following of women who came from all over the world to get PRP and stem cells in their vaginal tissue. And there was a group of them who were on tamoxifen, and it sets you up for that scenario where lichen sclerosis takes hold, like just the atrophy and the dryness, and then you get microbiome disruption that's significant, and the whole thing can snowball and further aggravate. Most middle-aged women, hopefully listening to this show, understand that the risk of autoimmune conditions goes up in middle age, and it's everything to do with the hormonal fluxes. And so
100%.
It's all of these things that are just not looked at. And I'll just add another for women whose intimacy with their partners is very important. This is devastating to marriages. This can be absolutely devastating. And yes. Culture at large, even several women, it's interesting whenever I mention anything on my Instagram about having sex every day, I get women angry at me, like just actually angry at me. How dare I say something? And I'm like, hey, this is part of vitality for some women. And it's very important. It's very important to their partners in some cases. And it's not doing a duty. It's like, this is part of some relationships. And it can be just absolutely devastating and send everything sideways for the whole family. Right. So I think of it as like microdosing estrogen. Can we, because we can even cut these patches in half. We can cut them down. We can give,
I've done that.
Yeah, you give a little bit just to get the symptomology. And in my patient base, like I said, it's predominantly pain we're trying to address, and it's migraines. It's, all kinds of different things, brain fog, but I don't give a damn about standard dosing. I care if I'm getting symptom relief. And whatever that dose is that dose, right? Especially in perimenopause when it's funny, my daughter, she said, because I overdosed myself on estrogen, I was on a standard patch, and after a while my tissue, I titrated myself up, and I was just having too much in my system, and my labs look great. Perfect. My labs were perfect, almost even low, but my symptoms said different. My symptoms were everything to do with way too much estrogen. And my daughter was like, I think you just need estrogen sometimes, Mom. And I said, it's so astute that you said that, because that's so true in the perimenopausal years.
Because it's all over the map.
Yeah. It's like sometimes I need more estrogen and sometimes I need less or none, because my ovaries are kind of petering out, but they're still doing something, And so anyway, I think of, some of these interventions probably causing that similar scenario. You would know better. You're seeing more patients on it, but it's almost like these poor women are going through perimenopause at a different phase, younger times if they're going through treatment at a younger age. And it's what a crazy hellish experience it is. I'm almost excited for my ovaries to go offline just so I can have endogenous control.
Perimenopause is really, really tricky because it's so erratic, right? Yeah. But the reality is for most cancer patients, they never get that. It's abrupt, right? It's abrupt. And the sexual symptoms, I just think we can't understate. I was 28 years old. I was only married 1 year to my college sweetheart. He's still here with me. He's the best partner ever, but it was devastating to us, right? And to think that there was no support, and to anybody who thinks that they're going to tell a woman who's 28 or 30 years old, and they're going to be on estrogen deprivation for 10 years to use some moisturizer, you know what happens 4 years later? And I see it all the time. 4 years later, they come back and they're like, I've tried it all. I've done the hyaluronic acid. I've tried the lubes. I've done all that. And at this point, we're dealing with a stenotic atrophied where the muscle now in the pelvic floor has become reactive to any touching. So then they get pelvic floor dysfunction. And I say, this is cruel and inhumane. And honestly, we could have easily prevented all of this from happening by using, at the start of the estrogen deprivation, before everything goes downhill, preventive care. So I use the analogy, they gave me preventative medications so I could tolerate chemo. I got steroids, I got anti-nausea medications, right? Anti-anxiety medications, so I can get through 6 months of chemo. And it helped me. Those extra meds helped me. When we know we are setting up a young woman for a decade or more of, let's just be honest, we know what's going to happen. And I'm sorry, lube doesn't prevent that. Why would we not give her at the same time a prescription for low dose vaginal estradiol, use it twice, 3 times a week, and prevent the downward decline? Now, if you're listening to this and this has happened to you, we can get it back. The vaginal tissue and all that, we can get it back with even just using local vaginal hormones. It's going to take longer, and it doesn't, it's not going to fix the years where you had sexual dysfunction and perhaps relationship breakdown. Or some of these young breast cancer survivors, they're 30, they're 28, they're 35. They may still be in the dating world. And so they have to get out there in the dating world. They don't even have a partner who they can discuss this with. These are life altering things. And imagine losing that part of intimacy when you're fighting for your life. Like the comfort of being able to be intimate and having that relationship. So this is, to me, sexual health is overall health. And some women abandon their cancer treatments because their sexual health has been decimated, right? So, I don't think a little vaginal dryness is the right PR term for what's happening here.
Yes, I agree completely. And then we can talk about the older gals who, that's a whole other conversation. I cannot tell you the amount of women that I have treated. So I did predominantly regenerative injection therapies. If I was applying hormones, it was for pain. It was to get people out of their pain state. And it's amazing what hormones and the right ratios can do. And it's different for everyone. Everybody needs a different cocktail, if you will, to get their pain symptoms under control. But these little old gals, they were just adamant. You probably get this too on your social media. Some of these older gals are just like, well, I went through menopause without any hormones and I'm fine. And they're like raw dog in menopause and they think that they should get a ribbon for it, And I'm like, some of us don't do so well without it, right? And anyway, these older gals, I would get these gals in their 70s and 80s, they would get UTIs. They would have no idea that they had a UTI because I would make them go pee on a stick before I would agree to inject them. I was not going to put a needle in their hip joint without knowing if they had some kind of systemic inflammation or infection going on. And lo and behold, so often these UTIs, and then they would start to get neurocognitive impacts.
100%.
And I'm like, this is nuts. This is crazy. And I'd say, hey, do you want some vaginal estrogen? Oh, no. I'm like, really? And trust me, it's so easy. Like I could save you the grief. Or I remember one lady coming in, she was suffering so miserably, chronic UTI. She was in her 70s. Her husband had passed away. And like you said, we can get the vagina back. The vagina is resilient. It's on, it's on the comeback pretty readily. But if it's a use it or lose it kind of situation as well. So the not using it just potentiates the losing it. And so she wasn't using her vagina anymore because her husband had passed. And I said, would you like some vaginal estrogen? And it was like, oh my God, she was crying the next time I saw her. Like, thank you so much. Like she was just living in utter hell. And when women past menopause, we're talking all about menopause and below, the older generations are
they suffered.
They're just discarded and forgotten and tortured. And it angers me at a level
and
I
the
can't
UTI
express.
thing, Rachel Rubin, people follow her on social media. She was a part of the new American Urological Association, GSM, Genital Urinary System Menopause Guidelines. And they made it very, very, very clear, not only that it's safe for breast cancer patients, but that it's safe and really important for this prevention of urosepsis, hospitalizations for, ascending urinary infections, pyelonephritis, which then can cause you to have cognitive changes, dementia, you could fall, you break a hip. I'm not being, inflammatory by saying this. These things actually happen. And they presented the data that using vaginal estrogen saves Medicare. If they just paid for estrogen for all these older women, it would save Medicare like gazillions of dollars.
Yes.
And profound decrease in hospitalizations and death.
Like
right?
70% like decrease in
numbers,
death.
Yes. And so the problem is that because we have a generation of women who were kind of ingrained and taught that just deal with it, suck it up, they're stuck with that. And then there's the fear-based label on the FDA approved vaginal estrogen products that, I get these comments every day like, well, I finally got the prescription from my medical oncologist or my GYN or whoever, but I opened up the label, Dr. Menn, and it says causes probable dementia, stroke, heart attacks, and breast cancer. They're like, so the label from the FDA says this, but my doctor says this, so I don't know who to believe. And so we're trying actively to get the FDA to remove that label, because we all know, and not just me, like the Menopause Society, like American College of OB-GYN, like major medical institutions, we all agree the data is clear that label does not apply to vaginal estrogen. It doesn't even apply to systemic estrogen, but it certainly doesn't apply to vaginal local estrogen. But it's hard to teach old dogs new tricks. I'm talking about the doctors, right? Yeah. And then the fear that this label, perpetuates, right? So we're working on getting that taken away.
Thank God. Thank God there's a whole army of you, and you're all growing your Instagrams, because it's we got to make enough noise. I just had a friend call me irate. She is in her 50s. She was going in to get cleared for pre-op for a surgery, orthopedic surgery, and unrelated to anything. She's on transdermal estrogen. She had a 65-year-old female physician who totally bitched her out for being on it, told her it was going to give her blood clots and kill her, and told her if she didn't go off of it for several weeks prior to her surgery, that she would not clear her. And my friend was like, but my inflammation and pain goes through the roof if I discontinue the transdermal estrogen. And she had called me and said, is this true? And I was like, God, no, it's not true. Like I have pages of data showing it's not true. But is there a minute risk? Perhaps, but everything that I have found adds up to transdermal not being nearly the concern as oral, if at all. They couldn't really conclude. And you might have better data, but I said, hey, let me send you this data to share with her. And this doctor said, I've been in medicine, X amount of years. I'm 65. I should know, and I'm female. I should know hormones. Literally just dismissed my friend completely. And I thought, how asinine that this is the world we live in, where other females are yelling down to patients with the wrong information. And if that was her comfort level as a surgeon or as a person clearing the surgery, okay, fine. But it was so denigrating.
But no, not fine. Not fine. Because you know what I actually think, and we don't have a study for this, but I actually think withdrawing someone who is stable on a transdermal estrogen, withdrawing her from before surgery is putting her in an abrupt new estrogen deprivation state, raising inflammation. And actually, I think you're going to raise the risk by withdrawing it. And I really believe that we have data showing the safety of transdermal estrogen, even in women who are at higher risk of clots, even in women who've had previous history of heart disease, MIs. The British Menopause Society has two beautiful statements that review the data on using transdermal estrogen in women in these higher risk situations. So there's a lot of ways we can lean into adjacent data to say, this doesn't make sense. We don't take people's ovaries out or give them chemical menopause before surgery, right? So then why would we suddenly take somebody off a transdermal estrogen? Now, someone was on an oral birth control pill and they were going to be in a state where they were in prolonged immobilization, right? There are certain scenarios. But it's become a knee-jerk reaction of you're on estrogen, you got to take it out. I'm like, this doesn't make sense. And where I see it a lot in the cancer world is in BRCA previvors. So women who carry the BRCA gene, who have never had cancer, who have had mastectomies to lower their risk of ever getting breast cancer. And then when they're done with their childbearing, they go in to get their ovaries taken out, or vice versa. Maybe they have their ovaries taken out and they've been on transdermal estrogen and now they're going in for breast surgery. And suddenly they are told at 37 years old that they have to come off estrogen for 6 weeks before and 6 weeks after. I'm like, this is insane. Don't you operate on 37-year-olds every day who have very high levels of estrogen? This woman is stable on a transdermal estrogen and an oral progesterone, neither of which raise an increased risk of clots. So this is bad medical care. And this is increasing problems, right? So that's a huge issue out there as well. The BRCA previvors, we could do a whole episode on those, because BRCA previvors have not even had cancer, but these people are completely mismanaged and undermanaged when it comes to their hormones, because many of these women are being put into premature surgical menopause to prevent ovarian cancer. And people are forgetting about the risks of premature menopause for these women. So I say these women can have their cake and eat it too. They can remove their ovaries, take them out. I don't want you to get ovarian cancer. You're done having babies. I can fix that. I can give you back your hormones. You can lower your risk of cancer and be healthy in terms of your hormone replacement therapy. These are the times where I will use replacement therapy because these are young women who we need to replace the levels up to that are mimicking what would naturally be being produced in your 30s, say, right? Versus a menopausal hormone therapy dose, which is lower, right? So, but these women, less than 50% of them are getting the appropriate hormone therapy that they deserve.
It's insane. And the removal,
It's insane.
The removal of the estrogen prior to surgery, just going back to that, what I don't think a lot of women understand is that hot flashes are vasospasms. That is what they are at their core. That is, they are that. I did a whole podcast episode about this. Like folks who are suffering with a lot of hot flashes, it is the harbinger of doom. It is not a good sign. And so pulling estrogen pre-surgery or for any reason, when we're worried about blood clot risks, and inducing vasospasm, like it doesn't.
And also wound healing. So,
huge.
Estrogen is really important for collagen production, for hyaluronic acid production of the skin, for wound healing, for immune function at the tissue level. And there's, I've been speaking to some plastic surgeons about this recently. I'm like, listen, like I've had some people tell me that they were like, their surgeon told them that they were shocked when they had wound breakdown at 32. I says, this woman is on estrogen deprivation with aromatase inhibitors and ovarian suppression. Of course she had wound breakdown.
Yeah.
She's been on these meds for 6 years or whatever the case may be. I'm like, her tissue is not like a 32-year-old's tissue. Her tissue is like a 67-year-old or 75-year-old who hasn't had estrogen on board. It's thinner, it's drier, it's less vascular, it's less resilient. We have to be considering the whole picture when we're treating these people.
Yes. I'm so glad you said that. Estrogen makes you elastic. That's what keeps you juicy. And without it, it's, oh man, that's such a good point. I'm so grateful that you are speaking out. And I found you really early when you came on Instagram, and I've watched your account grow, and I'm so grateful for it because it's really I know there's others speaking on this, but I do find you to be the authority, and I think you're so passionate about it. You've got when's the book coming out? We need a book.
I got my outline. I'm working on it.
Good. I'm glad. I was like, she needs books. She needs to be on all the shows. Like, we got to get this woman out there.
You're very nice. Well, it's really it's a labor of love. It's a passion of mine. And I just want women who are breast cancer survivors or other women who are dismissed particularly with premature menopause, to know you're not alone. We do have solutions. There are doctors who care about it. There are guidelines that are out there. We're not making new things up. We actually know what to do for you, whether it's hormonal or whether it's not, because again, I'm very careful. I always want anybody listening to this, if systemic hormone therapy is not in the cards for you, we can help you in so many ways. Please, it's not all lost, and it might be in the cards for you. And that's what I want to leave you with, that we can help you. And if anybody is dealing with menopause after cancer of any type, because it's not just breast cancer survivors, it's all cancers. I just want to shout out to my friend, Danny Bennington. She's in the UK. She has a nonprofit called menopauseandcancer.org. It is my favorite resource for people. She has a podcast. She's got free patient education resources. It's incredible. So if you're really looking for some evidence-based, vetted information, check out menopauseandcancer.org. If you're not if your doctor won't give you vaginal estrogen, the doctors at Alloy, we will prescribe you vaginal estrogen. So if anybody has a problem getting it, we're in all 50 states. You can get your vaginal estrogen from us. And if you need resources on how to navigate these hard questions about HRT or MHT after a breast cancer diagnosis, follow me. I have a course for patients, right? So, and then I have a separate one for healthcare clinicians who want to learn the ropes. So they can find that all at my website and on my Instagram. So
good. Okay. What's your Instagram? Speak it out. So we'll put everything in the show notes, but I want to make sure they hear it.
Dr. Menn, OB-GYN. So DRMENN, OB-GYN. And my website's just Dr. Menn, DRMENN. And for general menopause care, vaginal estrogen, sexual health, skin stuff, I see patients on Alloy, and then I do patient education, group consults and stuff through my private practice. Yeah.
Perfect.
Thank you so much for having me.
Oh, it's such a pleasure. I will make sure everything's in the show notes so people can find those resources.
Awesome.
And I really am grateful for you for taking the time today. So thanks for being on the show.
Oh, well, thank you for having me.
Thanks for listening to The Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.